una pregunta para Tom, en relación a que la mayoría de los hospitales de las listas que has mostrado eran de niños, Children's Hospital, Children's no sé cuántos. ¿Cómo está la atención a adultos? ¿Cómo está la fase de atención a personas adultas, no solo a niños? Se llaman Children's Hospital, pero ¿atienden a adultos también? ¿O qué pasa con eso en Estados Unidos?
It really depends on which hospital. There's politics in between hospitals, because I know some of them in the past have been bringing up to 30, 40-year-olds into the hospital and been stopped politically from internally, because a lot of hospitals are with hospital systems and they want to transfer those patients to adult hospitals. Now, there are programs being developed, which I wanted to get some more details on, where there's programs being designed to be transitioning pediatric patients to adult hospitals in certain disorders. My hospital is actually doing that in a couple different fields, and I was trying to get the literature before, but being Thanksgiving week, it came up kind of late in my brain to think, well, that's a program that would be appropriate for here. To present, but that's rare and far. Just like in a lot of places, adult patients, when you time out of the children's hospitals, you fall through the cracks, and that is a major issue in the United States, and I'm assuming here too. And it's not just limited to Exstrophy; it's almost all pediatric patients, because I've actually had the opportunity to meet. Because of all the other things I've done outside Exstrophy. Exstrophy came very late in my life in working with organizations with Exstrophy. I've worked with a lot of people with intestinal and urinary diversions on the side, and a lot of intestinal cancers, intestinal diseases. So they also have all the same issues. How do you transition to an adult doctor who may never have seen an Exstrophy case? That's very difficult, but hopefully that's something when you get these centers of excellence, and I'm assuming they'll be connected with adult hospitals in the area, and they'll have adult urologists. Maybe a transitional medicine can be lined up where they eventually move on to adult urologists who are now familiar with the pediatric patients growing up. So, because they have the contacts with the pediatric urologist. So I think that's a plan where across the board, no matter what country you're in, needs to be addressed. And if I would have thought about it quicker, I would have showed you a plan that's actually being implemented in Pittsburgh. Because we're affiliated with the University of Pittsburgh Medical Center, which is 19 adult hospitals on top of the pediatric hospitals, where they're transitioning. The doctors are working together with the adult doctors in that field. So unfortunately I can't give any definite answer what's better, because I went through that same process, and it's not fun. It's not fun trying to find an adult doctor that actually understands what Exstrophy is. So what I have done personally was I found a general practitioner who will listen to me, who actually listen to, and I have a pediatric urologist in my ear at work, so I use his advice to tell me where the best place to go. But that's a different perspective. And what does the adult patient want to do when they've actually, some people dropped when they were 15, 16, and now they're realizing they're having issues in their late 20s. There's a big gap there. They didn't handle it along the way. The resources are not there in the U.S. and a lot of places aren't there. So I think that's another place that this kind of organization will need to address if you're going for centers of excellence. Because centers of excellence, I consider, would be continuation of care all the way through adulthood. It's not. It doesn't just stop at 18. Does that answer your question? Yeah. Okay. Thanks.
Yo solamente voy a preguntar yo una cosa, Tom. Antes nos has dicho que el 40%, que el 40% de los pacientes con extrofia de Estados Unidos los operan en 3 hospitales. Es por saber el número. Puedes decirnos, porque el 40% con Estados Unidos es un número importante, o sea, no es lo mismo que en España, evidentemente, por hacernos una idea de qué cantidad de pacientes con extrofia estamos hablando que tratan en esos 3 hospitales. ¿Lo sabes?
Well, I can't give you a perfect number, but according to Boston Children's, there's 400 new cases a year inside the United States, and I was saying it's an estimate like between 30 and 40. Now I can't give you an exact figure because no one would release the data that I can find. But I will tell you though that over a course of 20 years, Johns Hopkins just followed their 1,000th case. So we're not talking even a lot of cases per year. Even in the U.S.
Es muchos.
Yeah. There's more
Sí.
Yeah, but part of the problem in the U.S. is we're talking distance. And you're talking a very expensive price to pay for travel and for lodging. And that's another issue altogether. That the medical cost itself is one thing, but you're traveling great distances to get to these places. Which increases a lot. But when they're following those cases, they're all following patients internationally too. So their numbers are all going to be skewed because of the international patients. And once you get an international representation, people are going to be traveling to that area who have money. So the number of cases they have could be skewed because of the international transportation to that care. But the problem is 10 years ago, I would have said that those three centers were doing most of the cases in the country. Today, I can't say that because of all the good training that they've sent urologists across the country. Very good, that were trained at those 3 centers, are now all over the place. So a lot of the patients aren't being transferred to those 3 centers because of that. So their numbers have come down a little bit. So.
Sí, bueno, en cualquier caso, para nosotros un hospital que tiene 1.000 casos, aunque en relación con el total de pacientes de extrofia de Estados Unidos no sea el 90%, pero la experiencia es muy alta. Es que compararlo con lo que nosotros estábamos diciendo antes aquí, que según nuestros datos, el hospital que más experiencia tiene en España, que es La Paz, bueno, luego el doctor Jareguiza nos dirá los casos, no los cuestionarios, sino los que tienen, pero estamos hablando de 100 pacientes, 100 y poco, y otros hospitales pues tienen 20, 30, 40, 50, claro.
I think that when you're presenting that data, you had an enormous amount of hospitals. So if you skewed them into 3 or 4 hospitals, you will have that critical mass where experience will give you total benefit, and especially in the cost analysis that you're referring to when you addressed your government. I think that's a very driving cost, because the cost. With healthcare in general, the cost is not just money, it's patient cost. If you have to redo a procedure at 2 or 3 different places, how is that being affected in the patient? Costs are measured in different ways. Pain is a cost. Life quality is a cost. It's not just, it's finances is a cost, but all those different have to be grouped together. And I think the work that you're doing with rare diseases and Exstrophy, all of that, it has to be taken step by step. I think your approach of trying to do the centers of excellence has to be commended. And I do think his one question about adulthood needs to be into that equation. Because there's no sense of having really good quality of excellence when you stop at 18. I mean, I know a lot of the other senators, they follow you to your order, but, you know, politics gets involved in that too. You know, hospital politics is great, as we all know. But that's even what you're dealing with the government also is an issue.
Hola, soy Elisenda, soy mamá de un niño afectado de extrofia epispadias máxima de 4 meses. Soy nueva en esto, conozco poco, pero quería hacer una pregunta en general, tanto a Tom como a todos. Para ver, era saber si hay algún tipo de estudio o estadística que dé algún número de afectados detectado durante el embarazo, o si hay algún tipo de estadística que divida los diferentes tipos de extrofias. O sea, que tengamos un baremo más o menos de cuántas cloacales hay, cuántas epispadias, cuántas vesicales, para poder diferenciar que me gustaría saber si hay algún tipo de estadística, tanto aquí como en el extranjero. Gracias.
Sí, nosotros sí la tenemos. De hecho, en la presentación que tuve en el Encuentro Nacional de Enfermedades Raras de Murcia hace unos días presenté las estadísticas del porcentaje con los que, según nuestra información, se han detectado o no en ecografías prenatales, y luego los que tenemos en ASEXVE con cloacal, con epispadias y con estrofia vesical. Así, bueno, podría recuperar la presentación, pero vamos, me parece que son el 80% de los pacientes son de estrofia vesical, o el 90% y muy poquitos de cloacal y de epispadias. Y que se detecten en el embarazo, muy pocos casos. Bueno, aquí puedes preguntar a los padres de los que tenemos por aquí, pues me parece que hay 1 o 2 que se detectan en el embarazo, y no porque no se pueda detectar, sino porque no se busca.
En esos 3 centros con más experiencia en Estados Unidos, la cirugía siempre la aborda un cirujano urológico, en algún momento la aborda un cirujano plástico.
You know, I'm not a medical person to answer that part, but I would say it depends on the practice. You know, I would say there's probably some plastic surgeons involved in some cases, but not, you know, it all depends on who's doing it. You know, I wouldn't even attempt to answer that question because everyone's individual. They're all different. So, you know, I wouldn't take that as a general rule. I don't want to be, you know, maybe you want to address the doctors later. It's some of the surgeons are well versed in doing those procedures. Some use maybe plastic surgeons along the way. It all depends. Yeah.
No, me refería en concreto si el cirujano es plástico o es urológico. Al menos sé que hay una gran diferencia entre uno y otro.
More than likely, it's probably a pediatric urologist. Is that the question? Yeah, I wouldn't want to answer that.
Doctor Jauregui.
Gracias. Yo no quería intervenir por no quitar tiempo a las preguntas, pero es una pregunta más bien médica. En definitiva, toda la patología de la estrofia vesical es tratada por los urólogos infantiles especialmente interesados en la estrofia, y desde el punto de vista cuando necesitan una ayuda y un apoyo de traumatología, pues evidentemente hay un traumatólogo siempre afín, cirugía de digestivo exactamente igual y cirugía plástica exactamente igual, pero en definitiva el peso del trabajo y el peso de la dirección del trabajo sobre la estrofia vesical es fundamentalmente del urólogo infantil.
La pregunta, Tomás, es mi experiencia personal. Conocí un hospital en Estados Unidos y entre uno de los aspectos positivos que veía es que este hospital tenía una zona para padres donde había una oficina de voluntarios asociativos. Entonces estaban coordinados con el hospital y se informaban de cada paciente que estaba intervenido, y cada nuevo nacimiento que llegaba era informado a la asociación para que esta asociación pudiera ponerse en contacto con estas familias. ¿Esto es de carácter general o solamente era de carácter particular? Me ocurrió en el Seattle, en el Hospital de Niños de Seattle.
I would say that's almost general and universal now in the U.S. That there's a lot of coordination being done, and maybe not just for exstrophy, but many disorders. We have that in our own hospital. I think it works better when you're dealing with the coordination for what the response you get. And I know you said you were at Seattle, so I know they do that a lot. So I think more and more places are setting up those coordination offices. So if that's what you're referring to?
Sí, sí. Me ha llamado la atención de que el Ministerio de Sanidad para el próximo año quiera quitar el tema de la cohesión económica de los centros de referencia y quieren que sean las propias autonomías las que tengan que sufragar el gasto de esos pacientes o esos ciudadanos de la comunidad autónoma al viajar fuera, lo que va por lógica a hacer que muchas de estas comunidades autónomas económicamente desastrosas pongan más pegas todavía al tema del traslado. ¿Qué opina FEDER o qué va a hacer FEDER o qué hay de esto?
Yo creo que el encaje que tienen realmente los fondos de cohesión evidentemente se está poniendo en tela de juicio. El fondo de cohesión fue la respuesta para mantener el sistema y asegurar la compensación entre las diferentes comunidades. El Ministerio habla de un fondo de gestión asistencial, un poco como un concepto todavía sin desarrollo para que fuera lo que sustituyera los fondos de cohesión. Nosotros ahora mismo estamos teniendo una serie de reuniones a nivel del Ministerio, de la Dirección General de Cohesión, de la Dirección General de Cartera de Servicios, y estamos presentando cuáles son las prioridades y pidiendo respuestas de cada una de las incidencias que las asociaciones nos han hecho llegar, clasificándolas y evidentemente insistiendo para que a la par que se anuncia que va a ser el año, se nos diga específicamente cuáles van a ser las acciones específicas que van a intentar abordar o responder a estas necesidades. Estamos teniendo esta acción a nivel del Ministerio. La próxima semana, la semana pasada, en cada una de esas reuniones nosotros hemos ido con nuestra agenda de prioridades muy clara. La verdad es que todavía nosotros no tenemos una respuesta. Sí que estamos presentes, seguimos insistiendo y en cada una de las reuniones salimos y lo primero que hacemos es enviar una nota de prensa insistiendo en cuáles son esas necesidades y cuáles son las propuestas, porque creemos que esto es muy importante. Cuando hablamos de enfermedades poco frecuentes parece que son tan inabarcables las necesidades que las propuestas serían igualmente inabarcables, y por eso cuando hablamos de 13 prioridades estamos diciendo los centros de referencia son una prioridad, tienen este ahorro dentro del sistema y pedimos respuestas sobre cómo se va a hacer la financiación, cómo se van a superar las rutas, las barreras que existen tan grandes para que una familia pueda viajar de una comunidad a otra, y esas son, digamos, las actuaciones que desde FEDER estamos haciendo. Estamos preguntando, estamos creando opinión, estamos presentando nuestras prioridades, no solamente con el conocimiento que tiene la Federación, sino asociado con expertos, con diferentes profesionales para hacer propuestas que sean fundamentadas, y ahora mismo no solamente estamos haciendo eso a nivel nacional, sino en cada una de las comunidades donde tenemos presencia. Luego hay que diferenciar entre qué es lo que nosotros evidentemente tenemos capacidad de hacer y cuál es la respuesta que las diferentes administraciones tienen la seriedad o el compromiso de darnos. Hay algunas administraciones que han comprometido ciertas acciones y luego no las han cumplido, y evidentemente ahí es también donde nosotros tenemos que hacer reivindicación y vigilancia. En este último trimestre, con ocasión precisamente de esa identificación del año 2013 como año de las enfermedades raras, pues nos han pedido una agenda de prioridades, la hemos presentado. Nos han pedido un listado de incidencias de cuál es el impacto que están causando las medidas de reforma en las familias con enfermedades, lo hemos hecho. Nos han pedido información y estudios sobre cómo esas medidas se están afectando o qué costes están teniendo en las enfermedades que se están viendo afectadas por la exclusión de medicamentos o por diferentes recortes, y lo estamos dando. Entonces nuestro compromiso es colaborar, evidentemente reivindicar, proponer y estar allí para no solamente colaborar con la administración cuando quiere colaborar, sino también reivindicar que esto no se está haciendo ante la opinión pública para que se haga. Entonces ahí es donde hablamos de que precisamente es importante que no solamente se escuche la voz de la federación, que es la que aglutina, sino que a lo largo de el próximo trimestre, que es enero, febrero, marzo, cuando todos nos unimos alrededor de estas propuestas y hacemos visible que somos un objetivo y una masa crítica, evidentemente cada una de las asociaciones, yo sé que Rosario moviliza muchísimo vuestra acción, hagamos visible allí donde no sea posible que las familias con enfermedades poco frecuentes, que cada uno tendrá una situación, una circunstancia, una enfermedad, estamos presentes y queremos respuestas. Queremos que evidentemente esos anuncios se traduzcan en palabras y estamos aquí para trabajar por nuestros derechos. Entonces, decirte, estamos directamente haciendo lo que nosotros desde la incidencia que podemos conseguir lo estamos haciendo, no nos estamos callando y también pensamos que tenemos que ser proactivos en la rapidez de colaborar y de proponer soluciones. Ahora, ¿cuál es la seriedad, el compromiso, el plan de trabajo que tiene el Ministerio o las comunidades, algunas que han decidido dar un paso y adherirse al año 2013? Esto realmente está en su terreno, en su responsabilidad. En el nuestro está hacer escuchar nuestra voz.
Bueno, quisiera hacer una pregunta a Tom, y es en referencia a esos 3 hospitales de Estados Unidos, que parecen ser que son los centros de referencia, ¿por qué tienen tanto número de pacientes tratados? Si es única y exclusivamente porque son centros de referencia, pues porque las técnicas o la investigación que los hacen ser diferentes al resto. Más que nada porque eso también nos podría servir de cara a plantear aquí en España tener centros de referencia, el hecho de que esos centros de referencia aquí en España sean el modelo a seguir de esos de Estados Unidos.
I think it has more to do with reputation and research, and the all combination of the two. They just grew up with great quality surgeons, and it's a lot of its reputation. You know, once you go out on the internet and you find out, most people see who's actually doing the research, then they try to go to that person. We don't have any official centers of excellence. You know, there's no official centers of excellence. So you can't really say they are, but they're the ones that are just encompassing the most patients. So once you get a critical mass of patients, quality will improve. You know, and I think that's why those places have become really quality centers. They had great surgeons to start, and they built a team around them. So, you know, to say, and it's like that in everything. I mean, everything in the U.S., and all the hospitals across the country, they all have their niche. And like, for example, the hospital system I work at, ours is transplants. You know, we're known worldwide for transplants. And livers, intestinal liver transplants. So people come to our facilities from around the world. And that's because they were the ones starting the research, doing the operations, had the great surgeons to start with. So it all starts with the basis of in the hospital community being quality, the surgeons being quality, and then building a quality staff around it. That's why I believe that if you're going to build centers of excellence here, it's a team concept. Everyone has to be coming in, that they don't see these patients once in a while. They see them once a week, every day. There's someone there. And because when it becomes secondary, that it's not a specialty. So I mean, a lot of us can relate. When we were in the hospital and other hospitals, we became the center of attention because we had Exstrophy. That doesn't always institute good quality healthcare. It doesn't make it bad either. But it doesn't, because what happens is you become the center of attention. All the residents have to come in, all the fellows have to come in, all the surgeons have to see you, because you are that special case. If you go to a center of excellence is developed, and they have, even though you have 30 cases, maybe you get it up to 50 cases a year, that's still one a week. then it becomes more routine, and they see them more often, so they can actually handle the complications more often. You know, that's where I look at it as a whole team. You know, you have the great nurses around them, the great radiologists, the great child life specialist around the team, around hopefully a great surgeon, and you develop a great all-around system. And I think that's what you're doing with rare diseases, trying to put them in centers where they build the team around for that disorder. And I feel that personally, but like I said again, I'm not a medical professional anymore. I deal with things on the side, but I do work with Exstrophy, with the ABC, and I've done a lot of patient work across the country, the U.S. But I've always seen from those kids that I've always worked with, no matter what the disability is, they were either had great parents and great surgeons and great systems they went through, or one of them was a failure. Either their parents were not great parents, or they weren't maintained at a great medical center. And either one of those complications manifest over time into adulthood. So I think it's really necessary to support your kids first and find great medical centers to take them to. And I think that with what this organization's doing, trying to find centers of excellence or trying to encourage it, I know there's always politics and in across the board in hospitals too. But I think it's a great first step, and I'm really impressed with what you've presented so far in doing it. I don't know if everything's the best to learn off the U.S., but we do have some good things to learn, and we have some bad things, just like everything else. It all takes learning from each other. You know, I think, to tell you the truth, when we were talking earlier in the week, just getting the amount of people in this room for how small Spain is a very big accomplishment. And it's very hard for us in the U.S. to get this many people in one room every year. I mean, last conference we did have 350 people at a medical center from 7 different countries, but it took 2 years of planning to do that. And what's being accomplished just for this one small weekend is remarkable. You know, just for a country of 50 million, it's remarkable. And you know, take that all as a benefit, and I'm really happy I was able to come here. And like I said, we can all learn from each other. Does that work for you? Thanks.